Hello everyone. So today we'll be talking about management of hypertension, right? And the latest guideline what we have from ACC AHA is 2017 guidelines for high blood pressures in adults. Okay, so we'll be mainly talking based on that guideline. Now this guideline mainly focuses on the aspects of prevention, detection, evaluation and management of high blood pressure in adults, and what I'll be talking about are the key points of what we should keep in mind when we are managing the patients of hypertension. Now, what is new about these guidelines in 2017? The earlier guidelines we were having were JNC7, that's Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure. Those were actually published in 2003. And now these 2017 guidelines would include newer things like blood pressure related cardiovascular disease, ambulatory blood pressure monitor, home blood pressure monitoring, and what should be the threshold to start antihypertensives, and even if you start, what should be the blood pressure goal, and how would you improve hypertension treatment and control, and various other important things which we'll talk about. Now, how would you categorize these blood pressure readings? Now, you should categorize this blood pressure reading as normal, elevated, or stage 1 or 2 hypertension, depending on what the levels are, and based on that you will decide whether you want to focus more on prevention or the treatment. So normal blood pressure is defined as less than 120 over less than 80 millimeters of mercury. What is elevated blood pressure? Elevated blood pressure is systolic 120 to 129 over less than 80 of diastolic millimeters of mercury. Then what is stage 1? Stage 1 is 130 to 139 over 80 to 89 millimeters of mercury. And stage 2 hypertension is defined as systolic of more than or equal to 140 or diastolic of more than or equal to 90. Now, it's important to remember that when they defined stage 1 and stage 2, they said either the systolic should be this or the diastolic should be this. So either or number, if you are falling into that category, that's the definition of stage 1 or stage 2 hypertension. So what I am trying to hammer home here is, like, for example, if the blood pressure, average blood pressure is 135 over, let's say, 70, do you think that's hypertension? Yes, because the systolic is more than 130, right? And what stage of hypertension would this be? So that's a stage 1 hypertension, right? So stage 1 is 130 to 139 systolic or diastolic 80 to 89 millimeters of mercury. Now, prior to labeling a person with hypertension, it is also important for us to use average blood pressure based on more than or equal to 2 readings on 2 different occasions. And these guidelines actually emphasize that you should titrate the blood pressure treatment or start the blood pressure treatment based off out of office or self-monitoring of blood pressure measurements rather than in office only measurements. Earlier we actually used to measure the arm circumference and the length of the arm to actually say that, okay, this might be the right blood pressure cuff for the patient. But now, since you have an index line in the blood pressure cuff itself, and you also have an arrow where they would say this is the arrow where you should be pointing towards for the brachial artery, and if the index line is falling within the range, that means that's the correct size of the blood pressure cuff. If it's not correct, and if the cuff is smaller, then it could result in inappropriately higher blood pressure reading or vice versa. Now, as I said, out of office blood pressure is something what ACC and AHA recommends in 2017 guidelines that actually predicts prognosis better than the office blood pressure. And here the level of evidence is A, and class of recommendation is 1. So it's something which ACC AHA really wants to focus on. Now, let's say when you ask the patient for out of office blood pressure measurement, you can come across various scenarios. Now, what if the patient has no hypertension in the clinic and no hypertension at home? What's that? That's normotension, right? What if the patient is hypertensive in the clinic and at home the patient is also hypertensive? That's sustained hypertension. What if in the clinic the patient is not hypertensive, but at the home patient is hypertensive? What is that? That's something called as masked hypertension. And this is something we all know about, white coat hypertension, that in the clinic the patient would be hypertensive, but at the home, via ambulatory blood pressure monitoring or home blood pressure monitoring, the patient would not have hypertension. So these are the four categories which you should keep in mind when you're using out of office blood pressure readings. Now let's say you're seeing a patient for the first time and who is never officially being diagnosed as hypertension, and the office blood pressure is 150/90. Now for this patient, it's reasonable to screen this patient for white coat hypertension using two techniques. Either you can use ambulatory blood pressure monitoring, that's ABPM, or HBPM, that's home blood pressure monitoring, to diagnose the category of hypertension. And the vice versa is also true. If the patient is normotensive in the office, but in the office you are seeing other signs of end organ damage, let's say somehow you get an echocardiogram and that shows left ventricular hypertrophy, or EKG shows some left ventricular hypertrophy, or patient is having some CKD and you are suspecting that's because of hypertension. So if in the office blood pressure is normal, and if you are still suspecting masked hypertension, it's also very reasonable to screen this patient for masked hypertension with daytime ambulatory blood pressure monitoring or home blood pressure monitoring. And it is very interesting to note that the blood pressure relationship to cardiovascular disease risk is continuous, consistent, and it's actually independent of other risk factors. Like for example, if the patient is hypertensive and if you compare the risk of death as compared to smoking or high blood sugar or obesity or outdoor air pollution, high blood pressure can lead to a lot higher mortality and deaths as compared to smoking, high blood sugar, and obesity. So, and in 2017, as per World Health data, hypertension led to 10.44 million deaths as compared to smoking, which took 7.1 million lives. Now, lowering blood pressure would have a very huge impact on reducing cardiovascular outcomes. And as per the study released in 2021, it was published in Lancet. This was a blood pressure lowering treatment trialist collaboration, and they calculated relative risk reduction. Now, lowering blood pressure would have a huge impact on reducing cardiovascular outcomes. Now, there was a study published in Lancet in 2021, and this was blood pressure lowering treatment trialist collaboration. And they compared relative risk reductions. So if you reduce 5 of your blood pressure, you reduce major cardiovascular disease events by 10%. That's a relative risk reduction. And if you reduce the blood pressure by 10, you can reduce the events by 20%. That's relative risk reduction. So that's regardless of the baseline blood pressure or cardiovascular disease history. So lowering the blood pressure would definitely have a huge cardiovascular mortality and morbidity benefits. And another important fact which we already know, and this is based off a Framingham study, that starting at 115/75 of blood pressure, the cardiovascular disease risk would double with each rise of 20 of systolic or 10 of diastolic blood pressure. So every 20 rise in systolic or 10 rise in diastolic would actually double the risk of cardiovascular disease. And for all the patients who were normotensive before the age of 55, 90% of them would develop hypertension in their lifetime. And why is that? It's probably because of age, related arteriosclerosis, or obesity. But most of them would eventually have hypertension with advancing age. Now, when you're seeing a patient, let's say you diagnose them with hypertension, what are some of the tests which you would like to order? Now, some of the basic testing for primary hypertension would include getting a fasting blood glucose, complete blood count, lipid profile, PMP, thyroid function, a urinalysis, and an EKG, with an optional, now this is what ACC-AHA guidelines recommend, with an optional echocardiogram, uric acid, and urinary albumin to creatinine ratio. Now, all of these tests directly or indirectly would test for end organ damage. Now, actually, coming back to the ambulatory blood pressure monitoring or self-measured blood pressure monitoring, what I was talking about, that ACC/AHA recommends out-of-office blood pressure more now. So, ambulatory blood pressure monitoring is actually the gold standard for diagnosing white coat hypertension or masked hypertension. The downside is it's cumbersome. You have to carry it, can disturb sleep because it goes off even when you're sleeping. The advantages are that it's more precise, it's less susceptible to bias and the placebo effect, and you would get many readings during work and the sleep hour as well. But more convenient and feasible is self-measured blood pressure monitoring at home. So now there are some of the websites, like for example validatebp.org or stridebp.org or Medaval medaval.ie. Now these three websites has a list of blood pressure machines which are actually validated. Now that's very, very important, because if you ask the patient for self-measured blood pressure monitoring at home, you want to make sure the blood pressure reading you are getting is accurate and is reliable. Now ideally you should ask the patient to take blood pressure in the morning, twice, maybe you space it out in the time. So let's say blood pressure in the morning, and of course this should be before the blood pressure pills or before any pills the patient is taking, so especially hypertensive if they are already taking that. So morning blood pressure before the pills, and repeat the morning blood pressure a little after a while, and do same at the bedtime. Now you also ask the patient to calculate the average blood pressure, right? So what's the average blood pressure in the first morning? What's the average blood pressure in the first night? And you actually give the number to the patient, and you actually teach them that, okay, what number you are trying to look for. That we want to target blood pressure systolic less than 130, let's say, for example. And of course you should advise the patient not to smoke or drink caffeinated beverage or exercise 30 minutes before measuring the blood pressure. Now I want to talk about some of the definitions of hypertension. Now earlier there was a term called as essential hypertension. Back in the era, the people were thinking that higher blood pressure is probably needed for that particular body because they want to perfuse their brain, and that's why they were using the term essential hypertension, which is no longer used now, which is now replaced by the term primary hypertension. So primary hypertension basically is idiopathic. You don't know the cause, whether it's your vasculature or the response of your vasculature to catecholamines. So it's an intrinsic mechanism which we are not aware of, whether it's the sensitivity of RAS, renin-angiotensin-aldosterone system. So primary hypertension is something which is idiopathic, where you just have to control, you probably cannot cure. That's the primary hypertension, because you won't be able to remove, let's say, all the vasculature in your body. Then is the secondary hypertension. Secondary hypertension is because of a cause, like for example, the patient is having pheochromocytoma, or is it something related to primary hyperaldosteronism, or renal artery stenosis, or coarctation of aorta, or Cushing syndrome, or pheochromocytoma. So those are the secondary causes of hypertension. So, and then finally, so we talked about primary hypertension, then secondary hypertension, and then finally we have a category called as resistant hypertension, where you are actually on 3 antihypertensive medication on optimal dosing, and you are taking those medications regularly, and you are very compliant with those medications, and out of those 3 medications, one of the medication is diuretic. That's the definition of resistant hypertension. Now there is also a term called as apparent resistant hypertension, that it looks like the patient would has a resistant hypertension, but that can have many other factors like non-compliance or non-adherence. Okay, so if the patient is not taking their meds, let's say you have prescribed 4 or 5 meds to the patient and you think the blood pressure is still high, but it's actually apparent resistant hypertension because the patient was not taking those medications. Now the ACC/AHA guidelines actually emphasized on screening for secondary causes of hypertension. When should you screen for secondary hypertension. Now you have to start thinking about secondary hypertension if the onset is before the age of 30, or if it's a resistant hypertension, that means more than three antihypertensive medications on optimal dosing. Patient is taking those medications and one of them is diuretics. Or if the patient has abrupt or accelerated hypertension, so everything was fine, but now suddenly patient has hypertensive crisis. Or if the patient has palpitations, headache, sweats, or if you notice an abdominal bruit or central obesity or purple striae, and if you notice the patient is having some hypokalemia or adrenal nodule, that's when you should start thinking about secondary causes of hypertension. Now, the guideline is really emphasizing on screening for primary aldosteronism, as primary aldosteronism is common and is almost always missed. So the prevalence in newly diagnosed hypertensives, the primary aldosteronism prevalence is 5 to 10%. So 1 out of 10 patients you see who you are diagnosing hypertension may have primary aldosteronism. And for the patients who are having resistant hypertension, the prevalence goes up by 20 to 25%. So the guidelines actually mentions that if you find a patient who is hypertensive and has hypokalemia, or has hypertension plus adrenal lesion, or has resistant hypertension, or has hypertension plus sleep apnea, hypertension plus AFib, or has a family history of early onset hypertension, stroke, or has a family history of primary aldosteronism, that's when you should screen the patients for primary hyperaldosteronism. And how much are we screening? It's just 1 to 2%. So that's something we should start getting better at. Now, what is recommended for the screening for primary hyperaldosteronism is as a simultaneous renin and aldosterone levels, and it's actually saying farewell to the aldosterone renin ratio. So you just answer a simple question. You just get a plasma renin activity. Is the renin suppressed? If the answer is no, that means the primary aldosteronism is unlikely, because in primary aldosteronism you would expect higher aldosterone and the renin should be suppressed. So if the renin is not suppressed, that means the plasma renin activity is more than 1, then primary hyperaldosteronism is less likely. But if the renin is suppressed, then you have to start thinking about primary hyperaldosterone depending on the levels of aldosterone. Like for example, if the renin is suppressed, let's say the plasma renin activity is less than 1 nanogram per ml per hour, and if the aldosterone is more than 15, potassium is less than 3.5, then it's very likely the patient has primary hyperaldosteronism. And it's very, very important to note that it's not necessary that all the patient would have lower potassium when you should start thinking about primary hyperaldosteronism. Even normokalemic hypertensive patient would have, rather normokalemic hypertension is the most common presentation for primary aldosteronism. So potassium would be just 4. So you just have to keep your eyes open. And this is based off the diagnosis and treatment of primary aldosteronism released in JIM in 2018. They mentioned that all patients with hypertension should at least be tested once for primary hyperaldosteronism. Now let's switch gear on the treatment of primary hypertension. Now, what is the blood pressure goal? That's a big universal question, right? How much should we target? Let's say this patient has some coronary artery disease, or patient has some other cardiovascular disease like heart failure, diabetes, CKD, or if the patient is having peripheral vascular disease. So what should be the blood pressure goal? And the universal answer here would be less than 130/80. Now let's touch a little bit on the management side. So what do you do for normal blood pressure? Let's say the patient's blood pressure is less than 120/80. So you just advise for optimal lifestyle habits. And when should you reassess? You should reassess the blood pressure again in 1 year, and that's a class 2A recommendation. Now what if the blood pressure is elevated? That means 120 to 129 over less than 80. Then again you advise non-pharmacological therapy, that's a class 1 recommendation, and you reassess the blood pressure in 3 to 6 months, and that's a class 1 recommendation too. Now, what is the next step in management if the patient has stage 1 hypertension? That is, the systolic is 130 to 139 or diastolic is 80 to 89. So here the important new thing is you have to decide based on the clinical atherosclerotic vascular disease or the estimated 10-year ASCVD score. If the patient already has established coronary artery disease and the blood pressure is falling under the stage 1 hypertension, then you of course advise non-pharmacological therapy, but you also start the patient on antihypertensives. If the patient does not have any clinical ASCVD, or if the ASCVD score is less than 10%, then you advise non-pharmacological therapy and you reassess the blood pressure in 3 to 6 months. So this is kind of a new stratification. If the patient is having stage 1 hypertension, then based on the clinical ASCVD or the predicted ASCVD score, if it's more than 10%, then you start the patient on antihypertensive medications. Now, let's say when you start these group of patients on antihypertensives, when should you reassess? You should actually reassess in 1 month. If the blood pressure goal is met, then you again reassess these patients in 3 to 6 months. If the blood pressure goal is not met, then you have to, of course, address and optimize adherence to the therapy first. Now, what if the patient is having stage 2 hypertension? That means systolic more than or equal to 140 or diastolic more than 90, then in addition to non-pharmacological treatments, you start this patient on blood pressure lowering medications. So you start this patients on antihypertensives directly. Now, when I mentioned about lifestyle modifications, it applies to all of the categories. And what does that include? That actually includes weight loss, DASH diet, sodium reduction diet, or low salt diet, or potassium rich diet in the food, encouraging physical activity, moderation in alcohol. If you were to choose that, hey, which one of the following is most effective in reducing blood pressure, the answer would be weight loss. Okay, if the patient is obese, the answer would be weight loss, and the systolic blood pressure reduction could be 5 to 20 millimeters of mercury per 10 kg loss. And of course, advising the patient on salt restriction or low salt diet is going to be very important, right? FDA recommends around 2300 milligram of sodium intake, and AHA recommends around 1500 milligram, but on an average, an American would eat 3500 to 4000 milligram of salt per day. And this is all, it's not just from the tabletop salt. That's a myth actually. The real salt actually is coming from the processed food, and you'll be surprised if you pick up any can and just look at the sodium level. The classic rule of thumb you should advise to the patient is if the sodium is more than 300, that's something you want to avoid, whether it's a canned soup or any canned food. Now, what are the first line medications which you would start if the patient has primary hypertension? And that's A, B, C, D except B, right? So it could be ACE inhibitors or ARBs, beta blockers. So that's not B. That's not a first line unless if the patient has HFrEF or myocardial infarction. That's not something we start as first line. Or so one is ACE inhibitors, ARBs, the second is calcium channel blocker, and the third one is diuretics. Now, how to improve adherence? And the adherence could be improved by once daily pills and using combination pills rather than prescribing individual doses. And most of the patients, especially with stage 2 hypertension, would require at least 2 antihypertensive to control the blood pressure. So it's very important to start prescribing combination pill therapy rather than single drug regimen. Now, when you have the the conditions like, for example, coronary artery disease or HFrEF, previous myocardial infarction, patient is having stable angina, you actually have to follow the standard treatment guidelines for these category first, and then in addition you have to add other drugs needed to further control the blood pressure. One of the important thing to note here would be you add the medication according to the comorbid condition. Like, for example, if the patient has HFpEF and has symptoms of volume overload, what would you add first? So you would add diuretic first to control the hypertension in these patients, which would also take care of volume overload, and then you would eventually add ACE or ARBs, and then subsequently beta blockers to titrate the target blood pressure of systolic less than 130. What would you choose if the patient has hypertension and you also want to prevent the recurrence of AFib? So ARBs can be useful for prevention of AFib. Now, some of the principles of drug therapy would include the following. If you are choosing diuretics as the first line, which diuretic you want to choose first? So chlorthalidone is the preferred diuretic as compared to hydrochlorothiazide. So because chlorthalidone is preferred because of longer half-life and it has a proven reduction in cardiovascular disease risk. And whenever you are prescribing ACE, ARBs, or direct renin inhibitors, you should not use all of these three drugs together, of course, because of the risk of hyperkalemia. And you have to also be careful about risk of hyperkalemia with ACE inhibitors and ARBs if you are using in the patients of CKD, or if the patient is already having some potassium supplements, or if the patient is already on potassium sparing drugs. So in those patients you have to be careful about ACEs and ARBs, and of course you have to be careful about ACE inhibitors and ARBs in pregnancy or in women of reproductive age. And out of calcium channel blockers are known to cause lower extremity edema, and non-dihydropyridine calcium channel blockers like verapamil and diltiazem, they are associated with bradycardia and heart blocks. So, and also they should be avoided in patients with HFrEF. Now, spironolactone and eplerenone, they could be added in patients who are having resistant hypertension. Like, for example, if they have already tried 3 drugs, including one of them is diuretics, then the 4th drug you want to add is spironolactone or eplerenone, or you would directly add this if the patient already has a diagnosis of primary hyperaldosteronism. And as I said, beta blockers are not something you want to add as first line, except if the patient already has a known coronary artery disease or HFrEF. That's when you want to start these patients on beta blockers. And which beta blockers would have actually mortality benefit? So mortality benefit would have bisoprolol, carvedilol, and metoprolol succinate. We almost never use just alpha-1 blockers for hypertension. However, if the patient has concomitant BPH, you can consider alpha-1 blockers in men who are having symptoms of BPH, but these class of drug can be very much associated with orthostatic hypotension. Some of the central acting alpha-2 agonists, like for example clonidine, they should be avoided and usually should be reserved as a last line due to the side effect profile, and these drugs have to be tapered. So these are the reason why you should avoid those medications. What antihypertensive would you prefer to start if the patient has CKD? Like for example CKD stage 1 or 2 with albuminuria, or if the patient already has CKD stage 3, you would like to start this patient on ACE inhibitors, right? And why do we do that? To slower the progression of kidney disease. Now, the ACC-AHA guidelines actually mentions that ACE inhibitors are something you want to start first, but ARBs are reasonable if ACE inhibitor is not tolerated, and usually it's the cough. So if you start the patient on ACE inhibitors and if they start coughing, that's when you want to switch these patients to ARBs. Now, same applies for diabetic patients, right? If they start having albuminuria, that's when you have to start this patient or ACE inhibitors or ARBs in the presence of albuminuria if they have concomitant diabetes mellitus. So those were some of the key points on on how to manage hypertension, how to diagnose, some of the definitions, and the drug choices. I hope that was helpful, and thank you for listening.